So first of all, I'd like to thank everyone and Chris for giving me the opportunity and inviting me to the meeting. It's an honour to be here, and it's good to see all of you. Now, I'm going to keep this fairly short and brief, but I just want to share my, I guess, personal perspective a little bit about Meldy-Barkman syndrome. This is where I refer most people to, and also myself. Obviously, we have our own website now, and Timothy Haynes' website is constantly updated, and I found it very useful. Now, why my interest in MdDs? Well, most of you might know I enjoy a mix of both clinical and research work, and MdDs in the neurotology community, I think it's a relatively uncommon vestibular disorder, and compared to some neurological disorder, it's pretty uncommon. So it is a bit of a mystery to, I suppose, many neurologists even, and clearly we need more research, and we have our own LM peers and doing TMS, cutting-edge TMS research in Australia, and clearly we need treatment that is going to lead to sustained improvement. Well, I think most of you know this, so I'm not going to repeat this, but we all know MdDs is really related to passive motion, so most of the people say it's cruising, and then some say flying, and the rocking and swaying is very characteristic, as you all know. And then when you go back onto that particular transport, the problem is relieved. There is a propensity for ladies to be more commonly affected by men. And when I started looking into MdDs, I thought that's the classic type, and I guess the spontaneous and recurrent types were sort of later on more described, but the spontaneous type is interesting because it's the minority, I think 5% off the top of my head, and recurrent type up to 20-25%. And I guess this is also a very big interest to me because when I look at MdDs, I like to look at it as a unique and well-defined entity, and I believe it. And I don't think one should mix and match it up with other vestibular disorders. And whilst people with MdDs often have migraine, I think vestibular migraine and MdDs are separate entities, so they need to be managed separately. And likewise, many people with MdDs have motion sickness, and that's another separate entity. Timothy Haynes talks about land sickness, so when people go from sea to land, for example, they get a bit sea-legged for a few days, and he thinks this is not the same as MdDs, where increasingly people are saying you've got to have symptoms for more than a month. Now, I really don't know how 1 month is derived, but that appears to be a reasonable cutoff. And I guess there has been some recent effort in trying to come up with a criteria of what MdD is. So passive motion, this exposure to virtual reality, I haven't actually come across anyone recently who developed MdDs from 3D or virtual reality, but I think physiologically speaking that is quite possible, and we might see more of it with virtual reality devices becoming more and more available. And symptom lasting at least for a month, and you should have normal balance function and MRI scan. So I think everyone should undergo at least basic balance function test and definitely MRI. And obviously, you can't explain the symptoms by another disorder. So I think this is a good starting point. Now, I think there's a lot of unresolved issues, and since I have a little bit of interest in MdDs, I think there's a lot of unanswered questions. Causes, that Chris referred earlier, that we don't actually know the exact cause or causes of MdDs. There's also this blurred relationship, and I think some of my colleagues like to say well, maybe it's the same as migraine, and it's the same as this newly defined entity, persistent postural perceptual dizziness. Maybe they're all the same. And there are, I think, some people, some neurologists or neurotologists who say, well, they're all the same. And also, what is the best method for treatment? To date, I'm not aware of a randomized trial comparing treatments. So this is really area of research. Now, I want to talk about causes. I must admit, originally, when I first heard about MdDs, I was very skeptical. So I thought perhaps it's all psychological. And I believe there are some of my colleagues and peers who think it's psychological. I must say to you that can't be more wrong. It is not due to a primary psychological issue. However, and I will come back to this later, psychological issues can become a secondary problem. Now, I guess scientifically, people have now come up with a few more theories. So apparently, the brain processing between different planes of rotation is mixed up, and that might explain why people still get this rocking and swaying after they come off the ship, so-called cross-coupling. And I think MdDs group has looked at maybe there's an internal clock which goes at 0.2 hertz, or 1 in 5 per second, and that clock, which apparently lives somewhere in the brain, is disturbed, and that leads to this rocking. And what about this propensity for female dominance? Well, maybe it's to do with reproductive hormone. And most of the patients with MdDs, most of the ladies, they get it between age 40 and 60. So there's some theories out there about the change in reproductive hormone may be related to the onset of MdDs. And that could well be true, but I think apart from the top one, I think 2, 3, and 4 are legitimate candidates for MdDs. But we need more research. Now, this relationship to migraine is also curious. I think most neurologists are now familiar with the idea of vestibular migraine, and to make it more interesting, many people with MDS also has vestibular migraine. We do have criteria for vestibular migraine, and I think it's very possible to diagnose vestibular migraine and MdDs in the same person, but I believe they're separate. There used to be a vogue that perhaps MdDs is extension of chronic migraine. I don't believe in that, and certainly I think if you read Timothy Haynes' website, he doesn't subscribe to that view either, and increasingly a lot of us don't believe the two are the same. And the reason, I think, is more and more we are understanding how the brain processes different motion, and there are some basic science studies suggesting that there are legitimate reasons why people might get MdDs, and it's very different from migraine. The reason why people get migraine is very different from why different people get MdDs. So based on that, you could say, well, you really shouldn't consider them as the same. However, I think migraine could be a risk factor for development of MdDs, and I think 50% of people with MdDs has migraine. So the two might coexist, but they're not the same. Now this is also a very taxing issue. What about this PPPD business, persistent postural perceptual dizziness? So the Germans come up with this term to describe people with chronic persistent dizziness. And now I think PPPD is recognised as a secondary vestibular disorder after you've had a primary disorder. So I look at PPPD this way. I think people get MdDs, and then with the passage of time, they can develop symptoms of PPPD. I look at it as a consequence, and I look at MdDs as a trigger. Now, there are some antagonists to this. They think this is all the same. And to make it worse, they think it's all in the head. And I think that is not correct. That used to be what I think, but I think after some years of looking at this and gathering all the relevant literatures, I think one can really make a distinction between the three different disorders. And I think it's really important that when clinicians, as clinicians, we try to help people by saying, look, you've got diagnostic category A, B, and C. The condition MdDs is already a complicated disorder, and if we mix up everything, it's even more confusing. That's my opinion. This, of course, is my personal approach, and I think everyone here would have different views about how this should be treated. There are various methods, and there's no studies, as far as I know, comparing one to another in large, randomized sort of studies, which we desperately need, really. So if I see someone with MdDs within 3 months, I would suggest they take a course of clonazepam, which is also what Timothy Haynes sort of recommends. Obviously, clonazepam, a benzodiazepine, is not for long-term use because of dependence addiction. This is not a good drug for long-term. And if the symptoms of rocking and swaying has been present for more than 3 months, I often recommend, an antidepressants. Again, there's some evidence for this, and Tim Haynes' group has done some work. Often I prescribe prophylactic medication before people endeavour to travel again. I know some people are not keen to travel again because, they might relapse. But I have found this somewhat useful in people. If they take a short course of prophylactic clonazepam, it often reduces or even abolishes the symptoms of MdDs recurrence. And I really try hard to diagnose and treat coexisting condition. I think it's really important. So if they have vestibular migraine, I think that needs to be diagnosed and treated. If people have PPPD, I think that needs to be discussed, diagnosed, and treated. Now, some of the clinicians may not agree with this, but I found it, if we can diagnose and put some symptoms in a category, in a basket, then it's easier for people to say, okay, these symptoms are due to that, these ones are due to that, and these ones are due to this. People find it easier. And there are increasing evidence to suggest perhaps physiotherapy might be useful. However, I think if you read Timothy Haynes' site, he said, well, our group has done a study. We're not sure. There's some interest in behavioural therapy in treatment of MdDs. I've mainly used behavioural therapy for PPPD, but I haven't actually said, look, if someone come to me and said, look, I had rocking for 6 weeks, I don't send them to behavioural therapy. I normally suggest they try a short course of medication first. That's my approach. Now, I'm sure Ellen is going to talk more about the novel and new, very promising treatment, TMS, repetitive TMS. But I'm just going to briefly mention about MdDs treatment, and some of you might have done it yourself. This is called optokinetic stimulation. And I was talking to him at the International Vestibular meeting, Barani Society meeting, and it would appear that the treatment is very successful, or the success rate is the highest in the first 2 months. The classic form, where people got off the boat or the cruise and they started to rock, they do better than the spontaneous form, where people just out of the blue got rocking and swaying. And for some reason, the younger one does better than the above 60. I think this looks promising, and it certainly, looking at MdDs setup, that can be replicated at home. I think it's a matter of time that, and with hopefully larger studies coming from the US, we might be able to disseminate this as a treatment. We desperately need more research. I think this is really lacking. Being an uncommon disorder, a lot of the MdDs patients, they probably diagnose the problem themselves first, and then they had to go through the process of getting the test. Now there's a criteria, we could apply the criteria, But many people have not, many clinicians have not heard of this condition or know very little about it. And I'll come back to my point that there's this thinking that it could entirely be psychological. I think that's quite unhelpful, thinking that this is all psychological, but I still encounter those sort of, people. And I guess we need to know what predict outcome. So how do we know someone's going to do well? Can we predict at the onset of MdDs? Can we know then perhaps they would do better if we give them this treatment? And what about medications? Clinicians like to prescribe drugs, and drug isn't a solution for everything, but are there particular medications that might be useful? And we desperately need to know which treatment protocols work in combination. Do we prescribe physiotherapy first, medication first, behavioural therapy, all three together? What's the optimal method? And we need more data about new treatments. They look really promising, but we just need more time and more patience outcome from these new studies. So how can neurologists help, and how can neurologists assist the MdDs community? Well, I think first thing is we as neurologists need to have a proactive approach, diagnosis, treatment. I don't believe in self-diagnosis. Patients should look up the symptoms on Google, that's fine, and then when they come, we should have a proactive and a empathetic approach in helping them establish the correct diagnosis and treatment. And like I said, diagnose multiple conditions if that's appropriate. And I think we also have this duty to try to increase awareness and understanding amongst even specialists and also general practitioners. I think most of you might have the conversation with your GPs, well, have you heard of MdDs? Oh, well, let me Google a little bit, and bang, it comes up, Tim Hang's website comes up. So I think many clinicians are not aware of MdDs, let alone the treatment and the research that's being carried out. Now, I think we desperately need to foster research between different craft groups. I think in the vestibular community, that's one of the beauty. Whether you're from clinical background, science background, physiotherapy, audiology, patient, we treat pretty much everyone as equal, and we like to collaborate and be able to foster research. And that's really important, I think, because this is such an uncommon condition. And if you could only move forward and gain more understanding of the cause, the best treatment, if you could collaborate and bring people together. I think that's really important. So I'm going to finish there, and I'll be very happy to take questions and whatnot.
I just wanted to know, when
Yes.
you're talking about prophylactic
Yes. Yes.
what does that mean?
So often a typical protocol I recommend is, say they're travelling next week.
Yep.
I often say, look, why don't you take the medication for 24, 48 hours before you board.
Right.
And then on your return trip, do the same. Some people have indicated that the 24, 48 hours isn't good enough, and I said, why don't you try 5 days? And that seems to have worked. I don't think Timothy Haynes' website talks about the duration, but he just said give a preventative course. So we don't know the optimal duration, but I typically suggest 1 or 2 days before you board the flight or the cruise, and then on your return trip, do the same. This is actually an area that we need more research. Like I said, 20% of people get recurrent form of MdDs, and we don't know who's going to get them. So one of the biggest fear, I think, is, talking to people about, well, could I travel again? I've got a cruise booked next year. Should I do it, or should I not do it? I think it's a pretty frightening thought that if they got it on their first cruise, and now they're looking at a family event, second cruise.
Well, I myself had it for a year,
Yeah.
and then it went away.
Yep.
One morning, woke up,
Yep.
and then it came back a year later again, and I've had it for a year again. So
Yeah.
it's a bit scary when you know
Yeah.
it's gone and
Yeah.
it's back.
And one of the other things I've observed is people get recurrent forms and then they get better. And then some people will get recurrent forms, and after a few recurrences, it became chronic and fixed. So we also don't know why that should happen, and what factors predispose people to that particular course. So we definitely need more sort of research. But I seem to think a preventative course of medication seems to work. I would also, on the topic of medication, I think it's a small part of the MdDs. All drugs have side effects. And I always tell people that, you know, drugs isn't the only sort of solution. And yes.
So what are the common names of the clonazepam?
Rivotril, clonopine. So those are the two common trait names.
It's not the Valium that you see people.
Valium is longer acting. The clonazepam lasts 8 hours or so it wears off quicker than.
It's the same class.
It's the same class, yeah. And Valium tends to build up, whereas clonazepam doesn't. So that's why I recommend it rather than taking Valium, because it can take a while for the drug to get washed out of your body.
What's
Yes.
the optokinetic treatment that you're referring to?
So MdDs got this full field black. So basically optokinetic stimulus consists of a black and white stripe, moving stripe, and you look at it. In some normal people, that can cause dizziness, and I think most people get dizzy if they look at very high speed black and white stripe moving in front of them. Now the theory behind it is that, well, if there is a internal circuit that's controlling the rocking swaying, if we can match it, maybe the brain can readjust. And that seems promising. I think, correct me if I'm wrong, Chris, but Margie is the only physiotherapist doing that in Australia. Is that correct? Yeah. So Margie in South Australia, she's a physiotherapist. She's the only one providing that treatment. I don't know of any other people providing that treatment at the moment, in Australia, that is. But MdDs group and Tim Haynes group in Chicago, they certainly are doing this treatment already.
What sort of success rate do they have?
Yeah, 40-50%, and it's the first 2 months. So what we don't know is what about a year later. So you obviously want this treatment to work in long-term fashion. And what if you stop the treatment? It seems to me that if you stop the treatment, the problem bounces back. So, you know, I think we need more studies about, and also why 40-year-olds do better than 60 doesn't really make a lot of sense. Could it be the hormones? Because, you know, 60-year-olds are post-menopause, 40 are not. So there's a lot of unanswered questions about optokinetic stimulation. Yes?
So is there any, looking forward to the future, let's just say for the longer term sufferers, more so than the younger ones, when you're
Yep.
saying, okay, you first come off the boat, that's
Yep.
how you feel.
I think what we're lacking is the cause. If we know the cause or the causes, I think we could do a lot to help people. And also, I think in many of the long-term patients I've seen, I think there are comorbid or coexisting conditions that need to be diagnosed and addressed. And it comes back to some of my colleagues would go, well, it's all the same, it's psychological, period, stop. I think that's the most unhelpful approach. And then some would say it's a form of migraine. So why don't we give you migraine treatment? That's more useful because at least you're not saying it's psychological. But I truly believe migraine and chronic MdDs are different entities, so they can't be treated as the same, because all the theories about MdDs, the theories on MdDs are very different from causes of migraine. And I think a lot of the MdDs studies recruit people with variable duration. So one thing we need to do is try to have studies where we go, well, we want 2 groups, 40 and then 60, enough in each group so we can say, well, what can we identify factors and on long-term follow-up, can we identify things that we can go, aha, because of these people tend to do better, or because of these, they tend not to do as well. And, I do, most of the patients, interesting, I've seen are recent onset one, because thanks to internet, Google, and then they say to their GP, I think I've got this, can you send me to someone? And so my discussion with them has usually been quite fruitful, and the treatment outcome has usually been okay. But sure, there are going to be people who are long-term, who only realise that's what they've got. And I occasionally have those people as well. So after 12 months, finally someone said, this is what it is. And I still give them the treatment based on my talk, and I can't promise that's going to get rid of their problem. But I think one of the things that is promising is, obviously Alan's work. There's a lot of buzz about RTMS and in general in neurology, and in a chronic condition like, and in MdDs, I think it's a very promising treatment. So, like all rare and difficult chronic conditions, we really need more research, especially for the chronic people.
Isn't it interesting that you brought up the VR goggles as a
Yes.
trigger?
Yes.
Even later down trackers using for treatment.
Yeah. I think actually, so there's been some discussion about using optokinetic stimulus, because you could trick the brain thinking you're looking at black and white stripe. And I think that could become a reality. Now, I have not personally seen people with VR-induced MdDs, but I think it's very possible, based on, I've actually tried out VR cruise on. There are softwares now that can put you on the cruise using VR. I've actually played a game, and it's very real. The motion produced, or the sense of motion produced by those VR goggles are the same as literally boarding. Yeah, I can't tell the difference. So with all these, and these are games basically, these are adventure games designed for children or younger people. And I would imagine with VR getting cheaper, a couple $100, you can get a goggle now, and the games are much cheaper now, that you will start to see people with VR-induced MdDs.
A lot of people with a lot of high room time, they're not getting outside.
Yeah. So I think watch this space. I think in the next few years you'll see this being reported, and I really don't know what to do with it. It wasn't an issue 5 years ago when VR cost thousands of dollars, but now with a couple $100, you can get it in your bedroom.
Will you be able to use that technology to offer treatment, perhaps?
Yeah, that's being discussed. Yeah, that's being discussed as a possibility. But one other thing I've mentioned is the durability of OK stimulation, optokinetic stimulation. It seems to me the first 2 months, and then after that, it's back to baseline. So I really don't know what's going to happen in 12 months and 24 months. I think that's where more research is needed, and I think the MdDs is definitely looking at that. And also, we don't know how frequently you're going to be doing it. That's another thing. The balance system is very flexible, and once you stop training it, it probably will go back to its baseline. And to me, when I look at those stripes, like I said, the faster it goes, the more nausea you get. So even in a normal subject like me, I feel nauseated looking at the very fast stripes. So I would imagine some people would get unwell looking at the faster one. And of interest, the early VR technology suffered from suffered from this problem because basically they're tricking the brain thinking they are moving. But what they need to do is trick the brain to think, you're not moving, the world is moving. But the early VR technology and 3D movie technology didn't do that. It only makes you think you're moving. And then the brain didn't like that. The brain likes to think, okay, I'm moving because the room is moving, then I'm good. But, and actually I think the VR technology now may be used to assist in treatment of MdDs, because if you can make the brain think, okay, you know, the whatever is surrounding you is moving, and I'm moving, and it's matched, then I'm good. So that's been discussed as well as a possible, and I'm sure Ellen's going to talk more about this, but you know, the internal, the circuit brain, there's been a lot of studies suggesting brain circuit is abnormal in MdDs, and the TMS strategy looks also very exciting to me. TMS has already been used to treat other neurological problems, Parkinson's disease, for example. So, in Parkinson's disease is a circuit, another classic circuit problem. So, I'm quite excited because at least now we've got people who are looking at it, whereas before it was all me saying, well, this is what I think we should do, you know.
Okay, any more questions for Luke?
Yes, please.
What's the difference between MdDs and PPDs?
Okay. Yeah. This is my personal view. Some clinicians think they're the same. So with PPPD, or persistent postural perceptual dizziness, the bottom line is people get persistently dizzy, but they often have a number of other symptoms, nausea, they feel wonky. Now, people with PPPD do not get better when they go back to the boat, or the train, or when they fly again. In fact, they often feel the same. So that's the classic difference, and that's why I think they're different. I don't think you should tell patients, well, it's the same, and I treat them differently, at least from a diagnostic point of view. Everyone with MdDs I've seen, they get better when they go back onto the boat or when they sit in the car again. But people with persistent postural perceptual dizziness, although they can rock and sway, they don't necessarily get better. In fact, they often don't. They stay the same when they go back to the particular mode of transport. And PPPD can arise from other vestibular condition, migraine, Meniere's disease, for example. So it's not an exclusive finding to MdDs, but I often see in especially long-term patients, because some long-term patients say to me, look, I used to get the rocking and swaying, and then it gets better when I go back to the car driving, and then I seem to have lost that. And that's where I thought, that's where I would consider PPPD instead. Now, you could ask, how do you diagnose PPPD? Is there a button you press and you go, yep, test shows this? No, and there isn't either for MdDs. And that's one of the problems. So we do need, I'm hoping if we have better handle on the cause, we can actually reliably diagnose the two conditions better.
Sorry, how would
Yes.
you treat PPPD?
I tend to prescribe behavioural therapy, specialised behavioural therapy, and some of you might have sort of looked this up. I think PPPD has always been, previously it was called psychogenic dizziness, so again, a psychological problem, or even worse, back in the 80s, a mental breakdown. That was what we used to tell people. I think that's most unhelpful approach, and a lot of these people, 20 years later, are still dizzy, and they invariably look up things. But the Germans have done a lot of work on PPPD, and they've got a PPPD clinic where they have a neurologist, physiotherapist, behavioural therapist, and they have found very good success in excess of 50% treatment success rate. And I think that's reflecting in my own clinical practice. I think behavioural therapy, plus or minus physiotherapy, plus or minus medication, people do quite well with PPPD. But like I said, I don't believe they're the same. Yes?
Can I say just that word dizzy?
Yes.
Because
Yes.
like, we don't, well, I don't know, but it's not dizzy. It's
No.
rocking and swaying.
Correct.
So I don't even know how that can be
Yeah.
compared. Like, it's not dizzy. No.
And I think that's a lot of people with the PPPD, sometimes they get dizzy when they bend over, and that's obvious, that's not rocking and swaying. Some people just say they're rock and sway. I think the term PPPD can be a little misleading because patients do talk about rocking and swaying in that condition as well. But the rocking and swaying, like I said, is not made better when they sit in a car. And PPD has more problem because it's changed names 3 or 4 times in the last 20 years, primarily because we called it a mental breakdown back in the 80s, and now things have moved forward. People have become more civilized and said, look, we can't label people as mental anymore, you know.
Yeah, I guess it's just more that word dizzy because I know when I was seeing different
Yes.
doctors, everyone,
Yeah.
I'm not dizzy.
Yeah.
Dizziness.
No,
You know,
and I think
that
most,
confusion.
all the MdDs people I've seen, they always say, I'm not dizzy, but I rock and sway. And that's the key. I think that's the key, one of the key symptoms you have to establish, you know.
So the PPDS,
Yeah.
do they feel the same like you're sitting in a boat?
They can,
They can,
But-
not all the time.
not all the time, but usually persist over months and years. But if you ask them, what if you're driving, or what if you go into a boat? No change. Then you know, well, they're really not having MdDs at that point in time.
Okay, thank you, Luke.
Thank you very much.
Thank you.
Yeah.